All right, finally, in the home stretch here, let's take a look at one of the biggest controversies that we encounter in bipolar disorder, which is the use of antidepressants and how to manage bipolar depression. So, as a general overview, thinking about treating bipolar disorder, there's this common axiom that if somebody is stable, we're going to go with the most tolerable medication first. And the reason for that is because we want them to try and stay on it, right? So we might use a somewhat less effective medication if it's more tolerable, if the person is stable. If the person is unstable, we're going to do whatever we need to do in order to get them well. And so, you think about a drug like haloperidol, pretty miserable drug to be on chronically, but very effective. Similarly, something like olanzapine, very effective drug, but not great metabolically. So we might shift medication strategies once we've achieved some stability, but we should really make that cornerstone, as I spoke about earlier, proven mood stabilizers, second generation. Antipsychotics can be part of that, but really we want to think about building a foundation with a second messenger modifier like lithium, lamotrigine, valproate. We also want to think about getting rid of meds that haven't worked. So a lot of times we're uncertain about deprescribing medications because we don't want to upset stability. But if something's not working, try and get rid of it so that we aren't adding extra burden of polypharmacy. And you want to think about treating side effects. You want to think about treating comorbidities to make sure that we are treating the whole person and not just getting myopically focused on the bipolar disorder. So there are a number of algorithms. Many of them are kind of aging at this point because we haven't created any of these in a while. They haven't changed too much, particularly with the treatment of mania. I mean, you're usually going to start with something such as valproate plus an atypical antipsychotic, also known as dopamine blocking drugs, or lithium and a dopamine blocking drug. If that's not working, then you're going to change strategies until you get some benefit. Fortunately, the natural course of mania is that it's not going to go on indefinitely. The problem is you don't really want to let people remain manic for a long period of time if we can avoid it, because that takes a real toll on the brain. People often fall into a pretty significant depression once that mania ends. And so the quicker we can get this mania kind of turned down, the better. But for some people, that can take some time. Most people, treating mania is actually the easier side of this illness. It's treating depression that's more challenging. So treating acute bipolar depression, again, kind of optimizing things such as lithium plus lamotrigine, quetiapine at moderate doses, like 300 milligrams, has a clear antidepressant benefit. Lamotrigine will probably help prevent the next depressive episode. And then we have increasingly drugs like lumateperone. Sorry, that didn't come out quite right on the slide. Cariprazine and lorazepam that have antidepressant benefit. There is this old olanzapine fluoxetine combination that was put out some years ago, but doesn't really have a lot of uptake. You could certainly combine those two medications together if you wanted. Ketamine is increasingly being used in the treatment of bipolar depression. Certainly seems to be effective. And then this question of what do we do after that? And it's kind of like the old explorer maps. Beyond here be dragons. We don't really have clear guidance as what should we do next. All these things are reasonable, but in what sequence should we use them isn't always really clear. TMS and ECT can certainly be used. And then this thorny question of where do antidepressant medications, the indirect monoamine agonists, come into this? So this will engender a lot of controversy. If you've been reading in the Gami book, you'll see that he's very opposed to the use of antidepressants in bipolar disorder, saying that these really are things that destabilize people's mood, that actually lead to longer term, greater morbidity of this disease and might actually cause harm. And on the other side, we've got this sort of more approach that says, hey, look, this is a disease that's largely comprises of depressive episodes with occasional mania. Antidepressants will work. People don't switch as much as we thought maybe they did. And we don't want to let people be depressed for a long period of time. So this is really kind of an ongoing fight. I personally kind of take a middle path. I generally will lean away from antidepressant medications, certainly not as a monotherapy. I will use them in combination with a mood stabilizer, but I tend to try and lean more towards the classic mood stabilizing second messenger modifiers whenever possible, and then use dopamine blocking drugs that have appropriate indications for different phases of the illness. So what about using antidepressants? Are they effective? They are. About as, about roughly as effective as they are in major depression, which is to say, not phenomenal, but nothing to sneeze at either. So this is an old study that looked at venlafaxine, sertraline, and bupropion, and compared them across the board, all reasonably effective. Now, the one question is, we know that bipolar depression isn't going to go on forever, just like any mood state in bipolar disorder. So how much of this was just people getting better anyways? Hard to know because there's not a placebo group here. But what happens if we stay on the medication? So this is with 10 weeks of data looking to see how many people actually switched. And they kind of parse this out into two groups. So one group being the rapid cycling group, which is the red bars, and then the non-rapid cycling. And you can see for people that have a lot of mood switches, the venlafaxine is probably bad news. So it kind of makes sense. It's an SNRI, as are most of the tricyclic antidepressants. And so, perhaps that combination, not a great idea. And it's also hard to know how much of this was, again, going to happen anyways, because if somebody's rapid cycling, by definition, they have a lot more cycles than the average person with bipolar illness. But this sort of, when I look at this, I start thinking more around bupropion because there were no switches in the non-rapid cycling group. And then if we follow these folks out over the course of a year, which is when we would really start to expect to see some possible shifting, the lowest odds of having a mood shift would be with bupropion. So the odds ratio is almost 1, meaning there was no difference between that and not using bupropion. So it's an interesting finding. Again, venlafaxine sort of this makes me think, SNRIs probably we should be careful with in folks with bipolar disorder if we're going to use an antidepressant at all. Now, what about bipolar 2? Remember, these are people that don't get mania, they get hypomanic, but they have a lot of depression. So should we use antidepressants with them? Well, it looks like that it will work. So what this is what's called a regression. This is a survival curve. So what we're starting with is we start with everyone being well. So we've gotten them into remission with one of these three drugs, the red being fluoxetine, the blue being lithium, and yellow being placebo. And we keep them on that and we follow them over time. And so you register on this graph here when you develop a recurrence of one of those symptoms. So that's why they call it a survival curve. And what you'll see here is that, the fluoxetine group, they did reasonably well. But in sort of over time, but in individual days, if we take a look at this graph here, the top right. So this is they ask them to rate their mood state, this is the mania score on the y-axis here, each day. And what you can see here is that there's a lot of kind of jaggedness. And so while these folks did reasonably well in aggregate, day to day, they may not have done as well as folks on either lithium or even placebo. So this is a trade-off, right? So you might get some benefit in the overall mood, but day to day, there may be some more of that sort of bumpiness in their mood and energy states. We know that younger people are more at risk for developing an antidepressant-induced mood shift, and that may be just because the younger you are, the less time you've been alive to really develop a pattern of symptoms. And so diagnostically, it's a lot easier to get this wrong because, a 14-year-old can be latently bipolar and we have no idea. But by the time they're 24, it may be really clear what the pattern is. So antidepressants tend to be a little more perilous in young people with regards to generating these kind of disruptions in mood as a result of starting an antidepressant. But the reality is, so this is what we're doing in practice. So looking at those blue lines, this is the total choice of medication for the first line of treatment. So mood stabilizers fortunately came out on top, but antidepressants are close behind on second. So what that means is that we're starting a lot of people with bipolar disorder on antidepressants, and I question the wisdom of doing that. So if we are going to use antidepressants, this is kind of the middle path that I've found, is that I may use an antidepressant, but I might only use it for a few months, and then I'll try and take the person off of it. So once I kind of get them out of the hole, I'm going to try and take them off the antidepressant, because what may happen is we end up destabilizing that person over time. And so whereas somebody with major depressive disorder, MDD, I might keep them on for 6 to 12 months. With somebody with bipolar depression, I might take them off after 2 or 3 months if they're starting to show some improvement. And I'm only going to do it when they have a mood stabilizing medication also on board as a prophylaxis against mood destabilization. If I'm going to use an antidepressant at all, I'll probably use bupropion. But if I'm not already using lithium or lamotrigine, I'm going to try and start that first. And then obviously if somebody start is stable and they're on an antidepressant and you start to see more cycling, they're having more mood episodes over time, you might want to think about taking that antidepressant off. And again, thinking about probabilistic thinking here. So this is how I kind of think it out. If I'm not if I don't think that they really have bipolar disorder, I'm pretty certain they're major depression. I'm more comfortable going with a classic SSRI type antidepressant. If I think that it's more of a cyclical mood disorder, maybe it's a bipolar 2, I'm at least going to avoid tricyclic antidepressants and SNRIs. I might think about adding a mood stabilizer. And the more I'm leaning towards it being a bipolar disorder, that's the more likely I'm going to go towards a mood stabilizer. And if I'm confident that they have a bipolar disorder, I'm going to stay away from the antidepressants as much as I can and lead more on the second generation um, sorry, second messenger stabilizers and messenger modifiers, and also the dopamine blocking drugs, particularly the ones that have antidepressant effect, if that's what I'm going for, or anti-manic effect, if that's what I need. There are things that we can be talking to our patients about beyond medications. One of the most important things is light and sleep. So really sleep is the cornerstone for all mental wellness, but especially in people with bipolar disorder, because this is that kind of energy dysregulation. These folks are often actually triggered into mania by sleep loss. So you see this in international travel where you're going east to west. You see this when people do shift work. You see this maybe the week after Burning Man or something, after somebody spent a lot of time awake in the middle of the night. So light is really, really important. Making sure that it's dark when people are sleeping, and then when they do get up, that they're exposed to bright light, especially if they're dealing with depression. You don't want people sitting in dark houses, avoiding sunlight when it's daytime. And this really kind of raises the question of like, what is remission in bipolar disorder? We generally don't get all symptoms to go away. So what I'm telling patients is that I'm looking, go back to drawing this simple drawing again. I say, what we're really trying to do is put in a ceiling. So when you do go up, you don't go as far up as you once did, and also put in a floor. So when you go down, you don't bottom out. You really just dip a little bit, and then you come back to this sort of longer periods of euthymia, hopefully with fewer comorbidities, with fewer, with greater functionality, and that you're happier, that your life is better, your relationships are better, and the things that matter to you, you're able to do. So I talk about having less time cycling, more time euthymic, and thinking about this really as, this is what we're going for in treatment of bipolar disorder. So next time we're going to talk about dopamine blocking drugs, which also play an important role in bipolar disorder treatment. But for purposes of this talk, we've just kept it to the second messenger modifiers. I hope you found this interesting, and I look forward to your comments in the class page. Thanks. Bye.